today's session is on sterilization, both male and female. That is vasectomy and tubectomy. So before you're planning for counseling a patient for sterilization, these are the prerequisites that have to be followed. You should take a both verbal and written consent. So this was not there in any other contraceptive. You were just taking verbal consent and no written consent. It should be conducted with both partners together, and you should give full information on sterilization procedure, its irreversibility and permanence. You should also tell them clearly that sterilization reversal is not funded by NHS. So it is not covered under NHS trust. So they'll have to pay for it if they have to go for reversal in future. Then you should give them full knowledge about the failure rate, the complications associated with the procedure. To tell them clearly that vasectomy is comparatively safer, quicker to perform, and is associated with less morbidity than female sterilization by either laparoscopy or laparotomy. You should also tell them, like, if you feel that the patient is not suitable for sterilization, you can give them option for long acting reversible contraceptives like implants or injections or IUCDs. Then assess individuals for known predictors of regret. We will be discussing what are the predictors of regret and highlight the possibility of regret associated with sterilization. Sterilization does not confirm protection against STI. Should tell them clearly, so they have to use condoms for the protection against STI. Should highlight the need of use of contraception until the sterilization has been carried out, and even beyond the procedure. So this we will be discussing, like post vasectomy, they have to use the contraception, additional contraception until up at least till 12 weeks, and even beyond if there are motile sperms detected, or more than 1 million non-motile sperm detected. So these things you should tell. Even for this female sterilization, at least for 7 days, if they have to take additional contraception. And for hysteroscopic, like if you're putting ashore, then for 3 months. So even after the procedure, they have to use additional contraception. Enable the individuals to make an informed decision and should include obtaining consent, which should be recorded and documented in the clinical records. Then about the consent, I've already told, written consent should be there. And in case you feel that the patient is lacking the mental capacity to give the consent, then you should, rather than refusing the procedure, you should seek for a legal advice. So it should be clearly documented, and because later on the patient can sue you. So for that, you have to get a legal advice if you feel that the patient doesn't have the mental capacity to give the consent. Then these are the conditions where the chances of regret are higher. If the female is young, less than 30 years of age, if she's nulliparous or low parity. Low parity means less than 2 children, 2 or fewer children. Being in an unhappy relationship, in a conflict with a partner or spouse, or who is not in a relationship. If there is remarriage or chances of remarriage, change of partner, change in relationship status. If there is a death of a child. If the patient still have a desire to have children and or more children, including with the new partner, if there are psychological problems or issues, implications beyond fertility issues, or if there is some caution by health professional or partner or spouse, if the timing of the procedure in relation to the pregnancy. So if it is done like interval sterilization, and results in reduced risk of regret. So what this means is, like, if it is done immediately post delivery, then the patient has gone through the stress of labor and cesarean. So that time, she might say that you do the sterilization, but later on she might regret it. So for this also, it is very important that you cannot, like, immediately, if the patient is saying during labor that she wants sterilization, you should not do. The consent for sterilization should be taken at least 2 weeks prior to performing it, so that the patient gets enough time to think beyond, and at any time the patient can withdraw the consent. Am I clear so far? Am I clear?
Yes, ma'am.
Okay. Additional care must be taken when counseling individuals under the age of 30 years or individuals without children who request sterilization. And this point is very important. Like tubal occlusion is performed at the same if has to be performed at the same time of the cesarean section, then counseling and consent, the agreement should be signed at least 2 weeks in advance. Immediately if the patient says you cannot do sterilization, then you have to do an interval sterilization. When a pregnancy occurs while an individual is on the waiting list for sterilization, they should be offered further counseling about the future contraceptive choices due to the change in the circumstances. Then, medical history. What are the prerequisites before going for a sterilization? A proper history should be taken. You have to do if you are doing a vasectomy, scrotal examination. For tubectomy, bimanual pelvic examination should clearly tell them that vasectomy carries a lower failure rate in terms of post-procedural pregnancies, and that there is less risk associated with the procedure than sterilization carried out by laparoscopy or laparotomy. So, coming to vasectomy. So, vasectomy, there are various methods. One is this no scalpel vasectomy. It was developed by a Japanese doctor, Lee et al. Basically it doesn't involve using there is no scalpel which is required. It just involves a puncture wound in the scrotal skin to access and occlude the vas. Following anesthesia, a specially designed fixation clamp is used, which encircles and firmly secures the vas without penetrating it. And then there is a sharp tip dissecting forceps which is used, which creates a puncture wound in the skin and the sheath of the vas. And then with the help of artery, you can stretch the opening, and the vas is lifted and it is occluded there. And from the same puncture wound you take out the second vas also, and you occlude it through the same procedure. So this is about non-scalpel vasectomy. However, it is not that popular in UK. In UK, what is most commonly done is minimally invasive vasectomy. So minimally invasive vasectomy, here you're using a scalpel, but the incision is very small. It is less than 1 centimeter, and the dissection area around the vas difference is minimized is and does not require the use of skin suture. So it is so small that you can just put a bandage and you do not require any sutures. Minimally invasive vasectomy may include the use of variety of surgical instruments, including the use of variety of scalpel to expose the vas. So in this you're using scalpel, and no scalpel vasectomy. You were not using any scalpel. You were just using a folding forceps and then a sharp forceps to puncture the wound. That's it. In this, you would require few instruments. Minimally invasive approach should be used to expose and isolate the vas deferens during vasectomy, as this approach results in fewer early complications in comparison to other methods. And this is the most commonly used method in UK. Then this was about the approach, like what approach should you use. Then what is the best method for doing mastectomy? So best method, this is again in SBA for you, that you have to do both. You have to do cauterization and then divide the vas deferens. So you have to do both. First you cauterize the two ends and then you divide it with or without excision of the segment which is in between it. Okay. The cauterization followed by division of vas deferens with or without excision, it is associated with the lowest failure rate and with least likelihood of recanalization when compared to other occlusion techniques. So you do not do division of vas on its own is not acceptable. So just dividing it is not acceptable, and just using a cautery is also not acceptable. Using clips is also not recommended. So you have to do both cauterization as well as division of the vas. This is something you should know. This is one of the SPAs. Then what kind of anesthesia you should use while you are doing vasectomy? So it has to be performed under local anesthesia. And consideration should be given to, because like you have to warm the anesthetic and anesthetic agent to bring it to a temperature of 37 degree Celsius before infiltration to reduce, because you're just using local anesthesia to reduce the pain during injection. Local anesthetic with or without adrenaline can be used, and local anesthetic should be administered via infiltration of subcuticular tissue and by direct injection to the vas deferens. And you should use a fine gauge needle so that pain is minimum. So these are the 2-3 points that you have to remember. You do it under local anesthesia. The anesthetic agent that you're using, it should be warmed to the body temperature, 37 degrees Celsius. You can use it with or without adrenaline. And the needle that you're using should be fine gauge needle. Then after vasectomy, you've done vasectomy, how will you counsel the patient? So you have to tell them that they have, like you have to confirm that the procedure is successful. Okay, so for that you have to take a post-vasectomy semen analysis. So that has to be done. This is again a question. It has to be done 12 weeks post the procedure. That is 3 months post the procedure. You have to collect the post-vasectomy semen analysis sample. Okay, until then, until it is proven that there are, I'll be telling you the criteria, that the criteria for vasectomy, like the successful vasectomy is met. Till then, they have to use additional contraceptions. Okay, then and whether you should send this if you have also like if you have divided the vas and with the removal of small segment of the vas, then should you send the sample for histopathological analysis? This is again a question. So that is also not recommended. You need not send for histological examination of the excised portions of the vas. Post vasectomy semen analysis should be done, and additional contraception should be used until azoospermia is confirmed, and this sample is done 12 weeks post vasectomy. And if one sample has confirmed azoospermia, then you need not do another sample. So that is not required to confirm azoospermia. Then about postal semen sample, like ideally it is recommended that patient should come to the clinic and give the sample. But if the patient lives far off and is not able to come, then you can also ask them to post the semen sample. Okay, however, for in that sample, you cannot assess the motility. You can just count the number of sperms if they are there. Okay, and then what is
Case
the
only failure, right?
yes?
Okay.
Okay, vasectomy failure. How is it defined? If you find at least any motile sperm after 7 months, so that is counted as vasectomy failure, or non-motile sperms after 7 months, which are more than 1 lakh per ml. Okay, understood. So any motile sperm after 7 months or non-motile sperms after 7 months, which are more than 1 lakh per ml. Okay, so in a small portion of men, non-motile sperm will persist post vasectomy. In such cases, special clearance can be given to cease using additional contraception when they are less than 1 lakh non-motile sperms. Okay, if motile sperms are observed in a semen sample 7 months post procedure, then vasectomy should be considered as a failure. Or if more than 1 lakh sperms, non-motile sperms are observed in a fresh sample, then again 7 months after vasectomy, then again clinical judgment should be used, and centrifugation is not recommended. So ideally, like if you have done vasectomy after 3 months, that is after 12 weeks, you should get azoospermia. But in case you're not getting azoospermia, then you have to see whether you are getting motile sperms or non-motile sperms. If it is motile sperms, you'll ask them for another 4 months to use additional contraception, and after 7 months you will check again. If after 7 months also any motile sperm, or if more than 1 lakh non-motile sperms are there, then you ask them to use additional contraception. It is a vasectomy failure. Okay, understood.
Okay, ma'am.
And when will you consult a urologist? So in case like while doing a scrotal examination, if you feel that there is double or duplicate vas, or vas cannot be palpated at all, or there is congenital bilateral absence of vas, so in all these cases you have to take a neurologist opinion. Okay, if a vast difference cannot be palpated, there can be various reasons. Either then, if on one side it cannot be palpated, then unilateral vasectomy can be carried out following appropriate counseling, and man should be advised to comply with additional contraception until the sterility is confirmed. The men should be informed of the probability of ipsilateral, because like if there is unilateral agenesis, then it is also a source of vas, it is also associated with renal anomalies. So renal agenesis can also be associated with it, so you should also advise renal ultrasound. Where apparent bilateral absence of vas deferens is encountered, then you have to consult a urologist. If double or duplicate vas is there, then again you have to do a Doppler to determine whether it's a true double vas, or sometimes there can be an ectopic ureter. So ureter is surrounded by this dense network of blood vessels. So you'll be able to identify it. So then you have to do a Doppler to differentiate it from ectopic ureter, or and you also have to get a urologist review. Understood?
Yes, ma'am.
Then additional contraception after 12 weeks. In what all cases will you use additional contraception? Ideally, after 12 weeks, if azoospermia is there, then you need not use additional contraception. Then that is confirmation of that vasectomy is effective. However, if 12 weeks post vasectomy, like obviously till 12 weeks, so you have to use, like, and then second, till less than 1 lakh per ml non-motile sperms are detected. So you have to use additional contraception. Okay.
Okay, ma'am.
Or if any motile sperm, that is so anyways failure only. Okay,
Ma'am, this 1 lakh non-motile
whatever. It
sperms
should be
after
more than,
7 months.
sorry.
After 7
No,
months?
even
No,
no,
no.
even
Ideally, after first sample you are doing post vasectomy semen sample, you are doing at 12 weeks. That is 3 months, right?
3 months. Okay. Okay.
Yeah. So at
even
3 months, if you get azoospermia, then there is no need of additional contraception, right?
Okay. Okay.
Okay. If suppose you're not getting azoospermia and you're getting non-motile sperm, then if it is less than 1 lakh per ml non-motile sperm, then again you can ask them that, tell them that there is no need for additional contraception. You can just repeat it at 7 months. Okay.
Okay. Okay.
So
Okay.
at 7 months also, if it is the same thing, then you can just leave it. Any motile sperm is detected, or if more than 1 lakh per ml non-motile sperms are detected, then you do it repeat after at 7 months, or at 7, and meanwhile you'll ask them to use additional contraception, and at 7 months also the same findings are there, then it is vasectomy failure.
considered as a failure. Okay.
Yes. Then after vasectomy, what advice will you give? You should ask them to contact their health provider whenever they feel that all these symptoms are there, like there is persistent bleeding, persistent pain, possible infection, or rapidly enlarging one-sided scrotal hematoma that would indicate being seen as a matter of emergency. NSAIDs can be given for pain relief or discomfort following procedure. You should ask them to restrain from strenuous activity post procedure and avoid sexual activity between like 2 to 7 days post procedure. You should ask them to wear tight underpants or athletic support for first few days, including at night for initial 48 hours or longer according to the symptoms. And you should also tell them about the post vasectomy semen sample that you'll be they for which they have to come at 12 weeks. If they cannot come, then you have to give them special bottles for semen collection. The collection, the this thing, the container in which you collect, it is different from the one which you are collecting. There are special containers, polypropylene, which are not toxic to the sperm. So you have to use those special containers, because if they are toxic to the sperm, anyways you'll get non-motile sperms.
Okay.
You have to give them those special containers to collect the sample. No prophylactic antibiotics before vasectomy is required. Skin cleansing in advance of vasectomy should be undertaken in accordance with local infection protocols. Decision to shave the scrotum prior to vasectomy should be based on local infection control and pre-operative policies. Then coming over to what is a failure rate of vasectomy? So it has a very low failure rate, 1 in 2000, that is 0.005%. Okay. Then sometimes, very rarely, patient complains of chronic pain after vasectomy. So vasectomy, it is associated with post-operatively testicular, scrotal, penile, or lower abdominal pain. That is rarely severe and chronic in some men. For that, this chronic post-vasectomy pain, also known as CPVP, you give them NSAIDs to elevate and treatment to elevate neuropathic pain. Okay, and if it's still not relieved, then surgical interventions can be effective in elevating CPVP. However, permanent relief is not achieved in every case. Okay, because it's mostly the neural pains. There are like in the sheath of the vas, the contents along with the vas, there are certain nerves also, like genitofemoral nerve, and these nerves can get damaged and they cause neuropathic pain. So for that, sometimes it get relief, sometimes it doesn't. So initially you can give these NSAIDs and like whatever you use for neuropathic pain like gabapentin and all. But if it's not getting relieved, you can advise them surgery, but you have to tell them clearly that it might not get relieved in every case. There is no evidence of an increase in testicular cancers associated with vasectomy. Weak association between vasectomy and prostatic cancer, which is unlikely to be casual, and no evidence that support an association between vasectomy and cardiovascular disease. So some studies have shown some association between vasectomy and prostatic cancer. Otherwise, it is not related to testicular cancer or CVD. Then about vasectomy reversal. It is a complex surgery that can result in high post-operative patency rates, but may not result in pregnancy or return to fertility. So it depends ki when is the patient coming. If the earlier the patient present, the chances of patency rate and pregnancy is high. So this table is from the guideline only. If they present within less than 3 years, patency rate is 97% and pregnancy rate is 75%. And if they present more than 19 years, patency rate is only 40% and pregnancy rate is less than 10%. So as the interval increases, the patency and pregnancy rate also decreases. I've not seen any questions from this table. This is just I put. Just remember, as the time increases, a patency rate and pregnancy rate decreases. Then coming over to female sterilization. So caldoscopy should not be used as a method of approach for sterilization. So that is not recommended. Then caldoscopy is when you go through the POD.
POD.
Okay, so that is not recommended. Laparoscopic approach to the fallopian tube is quicker to perform and results in less minor morbidity compared to mini laparotomy. And all the women should be informed of the risks associated with laparoscopy, and when this, like sometimes they, because of the complications, they might need laparotomy. Then there is a transcervical approach using hysteroscope, which is also called as hysteroscopic sterilization, where you're using this Assure micro inserts. You insert, so they basically cause fibrosis, and it also takes 3 months to act. So these devices, or there is Ediana in India, that's an Indian version, and Assure is an outside version. And so these are the micro inserts which are inserted in the fallopian tube, which block the tube and they cause fibrosis there, and that's how they block the tube. Then coming over to the surgical technique. So most widely used, we all know, is the Pomeroy's technique. In this, you use an absorbable suture material to tie at the base of the fallopian tube near the mid portion of the ampulla and excise the top of the loop. The suture material is absorbed rapidly, reducing the chances of inflammation and formation of fistula in the tube. After the sutures are absorbed, the ends of the tube pull apart, and the procedure you also destroy 3 to 4 centimeter of the fallopian tube, making reversal of the procedure more difficult. Then there is another technique which is called as modified Pomeroy's technique or Parkland technique. So in this, you separate a small segment of the fallopian tube from the mesosalpinx, and each end of the tube is ligated and the portion of the tube between the sutures is excised. So what you do, you tie sutures at the two ends, and you in between the sutures you cut the fallopian tube. That's Parkland. Then postpartum sterilization. So for postpartum sterilization, there is another technique. Laparoscopically, you're mostly using these Filshie clips. So you can either do modified Pomeroy's or you can do Filshie using Filshie clips. Filshie clip is quicker to perform. In this, you're using clips which mechanically block the fallopian tube, and it is a method of choice for laparoscopic tubal occlusion because it is easier to perform. The routine use of more than one Filshie clip is not recommended, so you have to use only one clip. If tubal occlusion is performed at the same time as cesarean section, this we have already discussed. You should take the consent when, if you're planning for doing sterilization along with a cesarean section. The consent should be taken when?
2 weeks.
Yes,
before.
2 weeks in advance. Okay, so these are the Filshie clips. So in India we are also using Philop rings, which in UK they are not using. So Filshie clips, these are made up of titanium. These are method of choice for lap sterilization, and you should not use more than one Filshie clips ever. So only one Filshie clip at a time for one tube. Then what anesthesia should you use for sterilization? So laparoscopic tubal sterilization can be performed using general, regional or local anesthesia, but in UK they are using general anesthesia. In India also we are using general anesthesia. And a topical application of local anesthesia to the fallopian tubes may be used whenever mechanical occlusive devices are being applied as a short-term post-operative pain gets relieved if you are using topical local anesthetic. Health professional can consider playing music. This is okay in the clinical room if the patient wishes, as listening to the music has shown to reduce patient anxiety. Then when should you perform sterilization? So this is important. So obviously within 5 days you can perform, or any time when you are reasonably certain that the patient is not pregnant. So when will you be reasonably certain? If she has not had intercourse like since the last 3 weeks. Okay, because negative pregnancy test does not exclude luteal phase pregnancy. So tubal occlusion can be performed at any time during the menstrual cycle, provided the woman has a negative UPT and has not been sexually active in the past 3 weeks. If she has been there has been an unprotected sexual intercourse in the past 3 weeks, then you give them additional contraception and you delay the procedure. You do not do the procedure. Okay.
Okay.
And during tubal occlusion, curettage should not be performed. So curettage is not recommended for the purpose of preventing luteal phase pregnancy. Then what is the failure rate of tubal sterilization? The failure rate is 1 in
After MTP we are doing it, no ma'am?
Sorry?
After MTP we are doing it, no?
After MTP, yes, we can do it. But this is when you're not sure about the pregnancy. So MTP, you are taking proper consent, no?
Yeah.
In this, you cannot perform because you're not sure. Then failure of tubal sterilization is 1 in 200. And what was the failure of vasectomy?
0.05%.
Yes, so it was 1 in 2000. So vasectomy is safer than tubal sterilization. Late failure resulting in pregnancy can occur any time after tubal occlusion, and the lifetime risk of tubal occlusion failure is around 1 in 200. And the longest period of available follow-up is for the Filshie cliff, where the failure rate is as low as 2 to 3 per thousand procedures at 10 years. Then about like if you have done tubal sterilization, so after vasectomy I have told you they have to like at least for 12 weeks they have to use additional contraception. After tubectomy also you have to advise for additional contraception. So if they are using CHC, POP, copper T, LNG, IUS, then you have to ask them that if there is just copper T and LNG, IUS, you have to ask them to retain it for like even after 7 days post sterilization, and after 7 days only to get it removed. Okay, this is important. Understood?
Yes, ma'am.
And
Yes,
if it's CHC, suppose CHC she has finished up, or POP she has finished the pack, then if you're doing it within the first 5 days of the menstrual, like if you're doing it, if she has finished the pack, or if suppose if like she's already on the pack, then also she has to continue COCs for at least 7 days post laparoscopic sterilization. Okay, so they have
Yes.
to continue for at least 7 days. And if they have
Yes.
finished the pack, then also they have to restart another pack and continue contraception for 7 days. So that is
Okay.
important. That additional 7 days it is required. Then, if
They
she's
should
on
follow mode of contraception post procedure.
sorry,
Any mode of contraception post procedure.
no, that's what I'm coming to. Like for POP, CHC, LNG, IUS, and copper T, 7 days is there. For implant and injection, you need not use any additional contraception. Okay. If it is in their this thing in the period, like implant is effective for 3 months, if for 3 years. So if during that 3 years time, if it is you are doing sterilization, then you need like immediately post removal of the implant, because what happens in this, they are releasing the hormone, the progesterone hormone in the blood, and it has a half life. So same with injection, but LNG and all are acting locally and they're releasing the hormone in a very low quantity. That's why. So for implant and injection, no additional contraception is required. If the progesterone only injectable or implant is being used, laparoscopic tubal occlusion can be carried out at any time during the period of licensed use without the need of additional contraception. Progesterone only implant can be removed at the time of the procedure or any time following the laparoscopic tubal occlusion. Then, like studies have shown that sterilization is protective for ovarian cancer, because ovarian cancer, it arises from the femoral end of the fallopian tube. However, there is no association of tubal occlusion and breast cancer risk, and there is no association between tubal occlusion and cervical or endometrial cancer. Only ovarian cancer risk it decreases. Okay. Understood?
Yes, ma'am.
Okay, and then it doesn't cause any change in hormonal or menstrual cycle. So no evidence, it doesn't alter any hormones, and no association between in tubal occlusion and increase in subsequent hysterectomy. But evidence suggests that there is an association between tubal occlusion and increase the risk of subsequent hysterectomy, but no evidence of causation. Women may report worsening of menstrual symptoms following tubal occlusion, but there is no evidence to suggest a causal effect. Then ectopic pregnancy risk is higher. So ideally, the failure rate is very low. However, if the pregnancy occurs, then the chances are there that it will be ectopic. This happens if tubal occlusion fails and the resulting pregnancy may be ectopic. Women should be informed about the symptoms of ectopic pregnancy, and the possibility of ectopic pregnancy should be considered in the women who have undergone sterilization and present with abdominal pain, especially in connection with missed periods. Then this table is very important from consent advice of female sterilization. So failure rate of sterilization, female sterilization is 1 in 200. Failure rate of vasectomy is 1 in 2000. Lifetime failure rate of sterilization is 2 to 3 per 1000 at 10 years. Then visceral or blood vessel injury at laparoscopy is 2 per 1000. Risk of laparotomy, conversion of to laparotomy from laparoscopy, it is 3 per 1000. And death post procedure, it is 1 per 12,000. So these things you have to remember from the consent advice. Okay. Okay.
Yes, ma'am.
Then last topic, hysteroscopic sterilization. These are flexible micro inserts, also called as assure devices. These are which are then passed through the hysteroscope and inserted into the proximal section of each fallopian tube. They basically cause benign tissue response called fibrosis, resulting in permanent occlusion of each tube after approximately 3 months. So this the fibrosis that they are causing, it takes to set that fibrosis completely, it takes at least 3 months. So for 3 months again, like for vasectomy also 12 weeks, that is 3 months additional contraception was required. For this also for 3 months additional contraception is required. Then anesthesia and analgesia for hysteroscopic sterilization is not routinely recommended. So there is insufficient evidence to recommend the routine use of oral NSAIDs or IV sedation for hysteroscopic sterilization. Use of such pharmacological agents should be based on the clinical judgment. Local anesthesia is not routinely required, and it should not only place where you should use local anesthesia is when you also have to dilate the cervix if the cervix is stenosed. Otherwise, you do it without anesthesia. Then about when do you insert these micro inserts? So you have to do it during proliferative phase, because if you do it later, there can be chance of pregnancy. There is a broad consensus that insertion of micro insert should be scheduled during the proliferative phase of menstrual cycle wherever possible. And advantages of insertion is that a negative pregnancy test is likely to rule out pregnancy, and visualization of tubal ostia is easier as the endometrium is not that thickened. Okay.
Okay.
Then unsuccessful attempt. Suppose you're not able to put it. So then how many attempts should you try? Only 2 attempts. If you're not able to put, you should leave it. Okay, you should ask them. Either you should refer them to the other setting, or you should give them another mode of contraception. And this is seen in 0 to 19% of the cases. Then post procedure, how do you follow up? You call the patient after 3 months, and you have to do either transvaginal ultrasound or X-ray. A confirmatory imaging test should be undertaken 3 months, and this may be via X-ray or a transvaginal ultrasound in the first instance, followed by an HSG in selected patients where these tests are inconclusive. So either you can do an X-ray, or first you do an X-ray or transvaginal ultrasound where you see that it has properly blocked. If you feel that it is inconclusive, then only you go for HSG. HSG should be used as a first line test where hysteroscopic procedure was considered suboptimal according to the local protocols. Okay. So if they ask you what is if everything is okay, then what will be the first line? If you have done it properly, and then either you do X-ray or transvaginal ultrasound first. However, if you feel that it was done in a suboptimal manner, then HSG should be done first. Okay. Understood?
Yes, ma'am.
Then
Yes, ma'am.
role of HSG, there was a concern regarding the possible perforation due to either excessive force and or sudden loss of resistance at insertion. And there was difficulty, if there is difficulty identifying the tubal ostia due to anatomical, so these are the indications where you do HSD. If there was difficulty identifying the tubal ostia due to anatomical variation or technical factors, or health professional is uncertain, or procedure time is more than 15 minutes, or micro insert with there are these trailing coils in the uterine cavity. So it is not completely placed in the fallopian tube. There are 3 to 8 trailing coils in the uterine cavity. Unusual post-procedural pain is there, either transient or persistent, or onset at some point post procedure without any identifiable cause, or if X-ray or transvaginal ultrasound is equivocal or unsatisfactory. So these are the indications where you do HSG. Okay.
Okay, ma'am.
Then additional contraception, this I've already told, for at least 3 months post procedure you have to use additional contraception. Women who do not attend for confirmatory testing should be informed that they need to continue using additional contraception until the tubal occlusion is confirmed. Then failure rate of hysteroscopic sterilization is 1 in 500 at 5 years of follow-up. Okay. Then questions.
Option D.
D.
Fine.
It should be a fine
Last one.
needle. You do it under local anesthesia, and it should be warm to 37 degrees Celsius. Adrenal can
Fine
use.
gauge noodle.
Yes, so it is. Next question.
12 weeks.
B.
Very good. Next question.
Division D, ma'am.
Yes, division alone is associated with the highest failure rates. Very good. The next.
Caldoscopy A.
Yes, very good. Caldoscopy. Next question.
C, ma'am.
D.
C.
Yes, they have to use COC. Restart the pack of the CSC, and for at least 7 days post procedure, they have to use COC. The next question.
Three months.
D.
Very good.
For 3 months.
D, ma'am.
Yes, there is no evidence to show that it improves bleeding pattern.
Yes.
B.
What?
Option B.
Yes, laparoscopy is associated with higher risk.
Coping yes. D, ma'am.
Yes, so either partner can be sterilized, but you should simultaneously give them an option of LNG RUS so that okay, because
Yes.
these vasectomy or sterilization will not control the bleeding. She's obese and has a history of heavy menstruation. So D is the answer. Yes. So very good. So this was all for today.